What is up, everyone? My name is Haney Malamat, and I'm here with Dr. Adam Green with the Critical Care Lounge. What is up, Adam?
Not much.
Now we're losing some of your sound, my friend.
Yeah.
It is coming in and out, but Adam is going to work on that. And let me tell you, folks, tonight we have a very, very good show for you. We are talking about pleural effusions. They're sexy, they're exciting, everyone loves to talk about them. Not really, but they should. And so we're going to help demystify some of the things that happen with pleural effusions, what types there are, when to drain them, and what to do. And tonight I'm rocking my 76ers shirt. Adam, do you know why that is? Now I completely don't hear Adam. The reason why I'm wearing it is because James Harden is now a 76er, and I am looking forward to a title in Philly. You there, Adam?
Be here. I don't.
All right, here's what we're gonna do. Let's try and hang up the call and do it again, and we'll be back in just 2 minutes. Give us a second. All right, and we're back. What's up, Adam?
Not much. Can you hear me now? Is this better?
There he is. The
All
golden
right.
voice.
I'm sorry. Hey, so you made a comment about no one wanting to talk about the pleural space, and I knew you were going to offend me. I just didn't think it was going to be 3 seconds into the show.
If I could have done it in 2 seconds, I would have done it in 2 seconds. I was trying to offend you as fast as possible.
Wow.
Are you excited about James Harden? Are you excited about James Harden joining the Sixers, or do you not care?
No, I'm very excited. We'll see. We'll see what it does to the morale of the team. I like the way they play. I love him as a player, of course, but we'll see. We'll see.
Some hesitation.
I guess you're ready. You're ready to buy a jersey and jump on the Harden bandwagon and get ready for the playoffs.
He's a great player. He's a great player. He has been able to stay on a team for any amount of time, but I just think he hasn't found the right team, and he has a team where no one's in his way. He can do his thing. You got Joel Embiid, and they also have Tobias Harris, right? I mean, They have a bunch of people on the they didn't trade Tobias Harris. Who they trade?
No. They're good. They got Tobias Harris. They got rid of
Seth Curry.
Seth Curry,
and
good.
Someone else who's really
Drummond.
Right. Yeah, I mean, Drummond was a big deal to come. So,
two first round draft picks too.
I mean, they basically sold their soul to get this one guy. And if he leaves after a season, I'm not a Philly fan anymore. I'm a Knick fan to start with, but
he can't leave after one season. But
I know, but they'll do something. He'll stop playing. He's going to grab his hamstring. He better not touch his hamstring coming out of the huddle, even if his leg's about to fall off. Is all I'm going to say. He has something to prove now, right? His legacy is on the line right here.
I see.
And James Harden had a pleural effusion. He had a pleural effusion once. Did you know that?
No, I didn't.
Yeah, no, he didn't. I'm just trying to transition into this talk right here, so I'm trying to find a way back in. All right, so welcome, everyone. Welcome to the channel. So glad that you can join us. If you're new to the channel, welcome. Thanks for watching. And like this video, subscribe to the channel. We're over 10,000 subscribers. 10,000 people, Adam, are subscribed to this channel. Pretty amazing.
I'll tell you, it's not because of me. It's because of you, my man.
That is not true at all.
That is a fact. Truth.
I was at 2,000, and then we started Critical Care Lounge, and then all of a sudden it's like 8,000 people in 2 weeks. It was amazing. It was amazing. All right, look, let's talk about it. What the plef are we talking about here? We're talking about pleural effusions. I'm going to ask you some questions. You are the guest this week. There's no guest. You're the guest. And I'm going to pepper you with all the questions and demystify pleural effusion because it can be hard, right? So the classic thing is you have someone coming with a pleural effusion and the intern says, I'd like to drain that effusion. Whether it's thoracentesis or pigtail, we'll talk about that in a moment. But when you're planning your approach, your anatomical approach to a pleural effusion, what is your approach for that patient? Is it individualized, or do you have a standard approach that you look at? Backside, tell me more about it.
All right, so let's break it down a little bit. So if I have an option and the patient's able to sit up and sit on the edge of the bed, and I can do a thoracentesis from the back, I'm going to do it from the back. Rib spaces are a little bit easier to get into. Anatomically, understand where the vessels are better. As you move around to mid-axillary line, things get a little more confusing. So if I have the option, I'm always going to drain from the back.
Okay.
Now,
so let me ask you then, ultrasound, are you using ultrasound every single time?
That's almost offensive. Why wouldn't you?
Well, okay. Well, I have questions about that because if you're saying the back is an easier approach and the side gets tricky, if you have an ultrasound that shows you there's a clear pocket in the posterior axillary or mid-axillary line, then why not go there?
Yeah, I think at times, so first off, the way you use the ultrasound, we'll go back a little bit. The way you're going to use the ultrasound is you're going to have it in abdominal or thoracic mode, right? Your dot is going to be facing up, always up, and you're going to place it firmly on the back, right? Nice, good contact. The problem is if you're on the back, not in the mid-axillary line, you're going to have an easier plane to understand. It's going to be easier to go in. There are not rib crossings. As you move farther into the axillary line, there are times where, first off, you have to really make sure you're perpendicular in both planes so that you can mimic the same ultrasound angle with your needle as you did with the probe, right? It's very easy to put the probe on, think you're good, put the probe down, grab your needle, try to go in. Because remember, these are ultrasound marked procedures, not necessarily ultrasound guided procedures like a central line would be. You're not using the ultrasound real time. You're using it to mark your position. And I just find, so of course I use it in every patient. Do I have a set rib space? No, I don't have a set rib space. I go where the best pocket is and I'll mark it and then I'll clean it and then I'll prep for my line. But so, preferably in the back. If I have to, in the vented patient, I can't get them up, then I go mid-axillary. It's just sometimes a little more technically difficult.
Gotcha. So ultrasound every time. You are not doing it under live guidance, and that's something maybe we'll come back to a little bit later. Would there ever be a case where you do it under live guidance? But as general, not under live guidance, you're going to make your mark. You're going to be cognizant of the angle that you got your image. And so for everyone at home, just if this is going to be an ultrasound probe, I'll just say, if you go perpendicular, then your needle is going to go perpendicular. What winds up happening sometimes is that sometimes people will come this angle as they're doing their ultrasound or this angle doing and then they come in at a perpendicular angle. And so if you're not coming in at the same trajectory when you're doing it, there's a chance that you're not exactly going to be in the space that you're supposed to be in or you thought you were in. Is that right?
That's right. 90-90, I would say 90-90. And I will say also, Haney, this is one of the reasons if I'm going to pick between a thoracentesis kit and a pigtail catheter, I almost always do a pigtail catheter. You say, why is that? Well, the thoracentesis kit is this big needle that you're going to try to, the patient's vented, their arm is up, you're going mid-axillary, they're in the bed, and getting that big kit 90 degrees sometimes is really challenging. You do you do a pigtail where you just have to get your guide needle in and then you can feed the wire in. A lot easier to get the correct angle.
Yeah, I love that. And actually that's something I do, but for a little bit of a different reason. My point being is that I hardly ever do a thoracentesis anymore. It's always a pigtail, right? Because the reason why is because the biggest complication for this procedure is puncturing the pleura, right? That's where all the complications are. So if you're doing all of that, you might as well leave a catheter in place so that over the next, hours to days, you can continue to drain everything out. It's very rare that you're going to get every drop of fluid out just with a thoracentesis while you're staying there. More often than not, you're going to terminate early for some reason, and there's still fluid in the space.
And let's be honest, we're lazy.
Yeah.
We don't want to sit there and take the time. We're lazy. We don't want to take the 20 minutes to drain it. We want to put the tube in, suture it in, walk away, and let gravity do the work.
Exactly. Perfectly stated. So great. So that's a pigtail. Let's just talk about, since we're here, are you ever using an open chest tube anymore, or a large bore chest tube?
Oh man. Um, where do I start? So I am an anti-surgical chest tube kind of guy.
Ooh,
So
anti.
I do not like surgical chest tubes, and I will make the comment that percutaneous tubes, and there's a lot of reasons for that. One of the main for me is procedural complications, less bleeding percutaneous, also comfort. Like open thoracotomy and putting a chest tube in, there's long-standing pain, neuropathic pain, and real pain that these patients have, and so I feel that it's safer, easier, and just as convenient for me to do a pigtail, and I don't lose anything. Now, the one scenario, well, I can think of two scenarios. Okay, I'm going to name two scenarios. First is traumatic hemothorax. If there's blood and the patient's crashing, surgical chest tube. That's the answer. The second is, now we're not talking about these pneumothoraxes, right? The other pleural disorder. We're talking about pleural effusions. There are times where pigtail drainage has failed once, usually once anterior, twice mid-axillary, then I convert to an open, to a surgical chest tube.
Okay, that's a very internist answer of you. I think that there are some surgeons that would disagree, that think
Yeah.
that that should be the primary. But I will say that the literature is definitely moving in favor of what you're saying. In other words, for trauma, the rule was, you got to stick a 40 French garden hose in there. And if you've ever been in a trauma bay and have ever seen this done, it is the most barbaric, grotesque, medieval stuff you've ever seen. People are screaming and people are like, just calm down. It's going to be okay. And how can you calm down when someone's like spreading your ribs apart when you're fully awake? So I'm completely on board. More and more data showing that you can actually use a 14 French for traumatic hemothoraces with equal success. So I think we're getting away from that. And there might be some situations where I find that you want to use it. That might be someone who's morbidly obese, who you have trouble getting in the space. So there's nothing like getting that finger in the space and evaluating. But again, it comes at the cost of a lot of pain, a lot of discomfort, and also getting a thoracotomy in a thoracostomy in somebody who's morbidly obese is also not an easy task as well. But I just find that sometimes it beats the percutaneous method for those reasons.
Well said. And the size thing, I'm no longer buying. You can get 32 French percutaneous tubes. So you can get large tubes that are put in percutaneously using Celdiger.
Really? Where have you
Yeah,
seen
yeah.
those?
Thalquick Cook makes up to 32 French, I believe. So we don't have them at Cooper, but at my old institution, we used to put large chest tubes in.
That sounds so painful.
Just dilate more.
Dilate more, right? You can always dilate more. All right. Well, let's talk a little bit about the diagnosis, right? So we kind of jumped ahead right into the procedure because that's what I like talking about. A lot of people like talking about. But let's go through and talk about how you would diagnose a pleural effusion. And then are there ways that you can tell the different types of pleural effusions by those diagnostic modalities?
Perfect. The pulmonologist in me is excited here. There's so much to talk about. And I'm going to make the statement. The problem with pleural effusion diagnosis is it's not the way we're trained. What we're trained to do is encounter a problem, say thrombocytopenia. Think of things that are common, think of things that could kill you, and work through our algorithm. Send more blood work, do more steps. You have an algorithmic approach to most problems. Now, what's the problem with pleural effusion? You stick a needle in, you drain it, you send all of your studies, and everything is sitting in front of you, and you have to then make a decision. So what I challenge people to do is approach a pleural effusion in a stepwise approach. Do not allow yourself to look at certain lab values unless they matter. And how do we do that? Very algorithmic. So the first thing I do, and I don't know if you want me to jump all the way into this, the first thing I do is I do not want to hear what the cell count is. I don't want to hear what the pH is. I don't want to know the diff. I don't want to know any of that stuff until I've decided, is it an exudate or is it a transudate? So the only things you're allowed to look at when you first are approaching the diagnosis is what is the pleural fluid LDH, what is the pleural fluid protein compared to the serum LDH and protein.
Well, let me ask you this. Let's talk even before you get into the procedure, because it might matter what type of tube you put in for the person, right? I mean, if they have something that is a transudative effusion, you might go with a smaller tube if you have it available just for patient comfort versus exudative, or are you using the same size tube no matter what, percutaneously?
Yeah, that's a good question. And I don't necessarily know the answer. I think for the most part, I only have one size of chest tube, so I picked the one
Hmm.
I have. I don't usually have the option of multiple. I think there's probably ultrasonography ways to differentiate between a simple or a complex effusion. There's probably, based on the clinical scenario and the way the ultrasound looks, we can say, oh, this is probably transudate. Let's just do a small tube. Versus, oh, this may be this thick, fibrinous, gross exudate that we're going to need a bigger tube because it's going to get clogged.
Right.
Um,
Right. And
so
certainly for the ones that are still holdouts for trauma, and or maybe someone who has maybe some hemothorax that's already coagulated, you might go for a larger bore tube. It might be helpful to know with ultrasound ahead of time. And as you described, and I'll say just break it down for people, when you have something that's called a simple effusion, or something that has very anechoic fluid around the lung, that tends to be consistent with a transudative effusion. Things like CHF, nephrotic syndrome, anything where you're having the pressure, fluid going across capillary spaces. And then whenever you have things that almost look like there's stuff in there, septations, or if you see large clots in there, that tends to be consistent with exudative, which would be a hemothorax, empyema. But until you test that fluid, as we're going to get to right now, you don't exactly know what type of fluid it is. So you might look at something that looks transudative, but actually winds up being exudative. Is that right?
that's right. That's right. And I love what you said there is that we get sometimes fixated on transudate, exudate, and I love that you broke it down from a physiological standpoint. So I would challenge people to think about when they approach a diagnosis of a pleural effusion, what is the physiology behind it? Is there incredibly high hydrostatic pressure in the vessels that are pushing fluid out into the pleural space? It's overwhelming the lymphatics and can't drain? Or is there some sort of protein high oncotic pressure within the pleural space pulling that fluid out? That's all transudate and exudate are. And because the reason it matters is we treat them very, very differently.
Hmm. So you get your fluid. Now you've done the procedure. You've gone posteriorly because that's the way you like to do it. And now you have the fluid. And the nurse says, what do you want to send? Walk me through what exactly you want to send. We'll get back, we're getting kind of back to what we talked about in the beginning,
Yep.
the things that you think are important.
Yeah, um, I have a set of things I send on every patient. And then there's probably a set of things I send if I'm concerned about certain diagnosis. So the things I send on every patient would be total protein, total LDH, cell count with a diff. I will always want those. I almost always will want glucose and pH of the fluid, but keep in mind, I don't always use them, but I only have one shot, right? I have to send it. I usually will send micro, and then sometimes cytology if I'm concerned about malignancy. Now, there are some other cases, which I don't want to get too much into the woods, but things like amylase, if I think that it's from a pancreatitis or esophageal perforation. Hematocrit for sure, if I think it's a pneumothorax. Remember, the diagnosis of pneumothorax is not the number of red blood cells, but the hematocrit and what it is in association with the serum hematocrit. ADA, if I think it's TB, that can be very helpful. And then there's weird diagnoses like chylothorax and urinothorax, which I send specific studies for.
Fantastic. So that's a great overview of the things. It's based on your pretest probability and what you're going to send. Okay, so once you diagnose an exudate, all right, what are the next steps for you to do? Let me give you an example. Let's say you're worried about an empyema. What are the things that
So,
you're going to do next?
so I do the same thing no matter what I'm worried about. So I
Okay.
decide it's an exudate. The next thing I'm allowed to look at is the cell count and diff. That's it, okay?
Okay.
So all I'm really wondering is it predominantly neutrophil or is it predominantly lymphocyte? Because
Okay.
they take me in different situations. Lymphocyte's easy, right? Lymphocyte immediately makes me concerned about malignancy. That's an underlying etiology. The other things, which we don't see all that frequently, but I saw in my fellowship quite a lot, would be TB pleurisy. So a
Hmm.
high lymphocyte count, I'm immediately worried about a tuberculous effusion. And then there's like weird things like, viral or some of the effusions due to autoimmune diseases that, let's be honest, when was the last time you tapped an effusion from RA? Like it's possible, but probably very, very rare that we see that, and it's big enough to tap. So that's lymphocyte. Now, neutrophil, immediately thinking about infection.
Gotcha. Perfect. So well stated. All right, let's get into a little bit. Infected spaces. So you've confirmed that there's a bacterial infection. Do all of those infections need to have a thoracic surgery consult for potential intervention? How much do you drain out? Do they need to be completely drained out? Walk me through what you do for these people.
Okay. So an infected pleural space is a spectrum, okay? And they will advance along the spectrum unless you intervene. And I'm going to take the scenario, just be patient with me. I'm going to say that they have a pneumonia, okay, and that's the source. Now, does that mean that someone with acute cholecystitis can't develop an empyema as it translocates across the diaphragm? Of course they can, right? Are there other, can a long-standing malignant effusion end up getting infected? Yeah, probably, right? But let's just say they have a pneumonia, all right, and it usually follows a simple pathway. It goes from what I'm going to call a simple paraneumonic effusion to a complex paraneumonic effusion to an empyema. Now, you will see a lot of people say, we'll throw a lot of definitions out. And so I break it down in this way. A simple paraneumonic effusion simply means there is a pneumonia, there's a reaction process occurring because of the inflammation from the pneumonia, and as a result, there is fluid. The space is not infected, okay? It is an effusion due to the pneumonia, but the pleural space is not infected. What do? You diagnose it, you drain as much as you can, you don't obsess over every drop, you get your tube out, you don't need thoracic, you don't need VATS, you don't need lytics, you don't need any of that stuff. Now that's different than the spectrum of complex paraneumonic / empyema, okay? Those, you got to get everything out. That's how you're going to get source control, because there's bugs within the pleural space. Now, you're going to ask, I'm assuming you're going to ask, what's the difference between complex paraneumonic and empyema? The answer is easy.
Are you going to just assume that, or are you going to let me ask you that question?
Yeah, ask me.
No, just go ahead.
I'm just all fired up. I know
this is like, if you really want to touch a nerve with a pulmonologist, ask about pleural effusions, apparently.
Well, yeah, they like asthma and stuff. I like the pleural space. So empyema, you put a needle in and you say, crap, that's infected. There's no doubt about it. Anyone who's drained an empyema, know they drained an empyema. It smells like pus. It looks like pus. It's pus. To me, that's a diagnosis of an empyema. There's no doubt in your mind. Sure, I'll buy like a positive culture. That probably counts too. But usually that's definitely an empyema. And I've never met someone with an empyema that doesn't jump off the bed when you bang their back, right? If there's truly an infected space there, they're tender.
Right. And so what's the management there? You want to try to get as much out as you can, but is that followed up by a thoracic call for possible intervention, or do you give them a trial?
Yeah, so it depends. The answer is it depends. So we put our tube in, right? We only do we only do pigtail catheters, like we said. And if it's loculated and you can't drain at all, and how do we know that? Usually based on imaging, then you have two choices. Do you give TPA Dornase, lytics to try to break up the loculations, or do you call your thoracic surgeon for VATS? And my answer is it depends on the person. So if it's a young person, I'm calling my thoracic surgeon, right? If it's an old COPD, unstable, probably can't tolerate the surgery, then I'm going to do lytics. And the reason for that is simple. The longer you wait, when you then take that patient to the OR, the more likely they're going to be switched from a VATS to an open thoracotomy. So if it's a young guy, yeah, I'll drain it, I'll prove it, I'll call my thoracic surgeon buddy and say, I think you should probably do a VATS on this guy.
Gotcha. And is there data that has looked at these two approaches head to head?
Correct. Yeah, that's what that comes from.
Yeah. And so younger people tend to do better with that approach. Older people tend to do better with percutaneous approach.
But what the data shows is that lytics are capable of achieving adequate source control, but the longer you wait, the more likely you have to switch to open thoracotomy when you go to the OR.
Gotcha. All right, perfectly stated. All right, let's switch gears a little bit and talk about the size of the effusion, because we jumped into this just saying pleural effusion, just generic pleural effusion, but they come in different sizes, right? And that is something that has been looked at, how to use ultrasound scoring systems. But I think, at least I'll speak for me, I'll listen to you, the expert, about how you grade your size of effusion. For me, I look at it with the ultrasound. I've seen enough that I can know whether or not something is small, which is moderate, or large. How do you score it? Are you actually using like volumetric cylinder models like some ultrasound gurus have talked about?
Well, I think you're looking for some fancy answer, and I'm not going to give it to you.
That's fine.
Remember, I'm a simplistic dude. I am. So here's my scoring system. Trace means everyone who ever looked at it would say you can't tap it. Small means, yeah, it's there, but I don't want to tap it. Moderate means, okay, I'll tap it. Large means, oh man, that's filling up my screen.
Yeah,
that's how I do it.
Right on. And then when we get back to you said you don't use live guidance, but do you ever find situations where you want to sample the fluid, let's say a small pleural effusion or small to moderate for diagnostic purposes, where, and I'll use the number that I've always heard. If it's less than 10 millimeters, from the lung is less than 10 millimeters from the pleural line, it is at significantly higher risk of causing a pneumothorax if you were to put a pigtail in. But is in that situation, would you use live guidance to watch the needle going in just to take a sample for diagnostic purposes?
Yeah, I've heard that. Generally speaking, when I look at the effusions they're talking about, they're usually ones I'm not all that excited about going after.
But so I'm saying in a diagnostic case, like if you need to,
even diagnosis, I don't know. But what I'll do, so I don't know, maybe you're good with it. I use the phased array probe, and I cannot find an easy way. It's not like the linear probe. I can't find an easy way to hold it, get my needle, trace my needle. It's just a lot harder. And I've usually found that the linear probe doesn't necessarily have the depth you need to sample. Yeah. So what I'll sometimes do is, I mark my spot, I go for it. Let's say I fail. That's usually what happens, right? You're going in, you're pushing in, and you're like, oh, I should be there, but I'm not getting any fluid. I'll remark it, and then sometimes I'll attempt to see it and trace it but I've usually found it just more challenging than it's worth.
Gotcha.
But maybe there's better ultrasonographers than me. I'm sure there are that can do it.
Yeah, well, generally what I do is the same thing I do if, we have a patient who is tamponade that can't get to the cath lab and needs drainage. This is my approach. The first step is to use a larger depth probe. You can use phase array, you can use curved linear. And essentially what I want to do is I want to gauge how deep the effusion is. I want to know how deep we are from the pleural line to the lung. I just need to know what those numbers are. Then if we're talking about a large effusion and I know that we're at a certain depth, I'll switch to the linear probe, and then in real time I'll know my depth. So let's just throw some imaginary numbers out there. But 5 centimeters is when I get to my lung. I'll use the linear probe and say, well, I can only see up to 4, but I'm not going to go deeper than 4, watching my needle come in plane into view. So that's a way that I can't see the true depth of the structures, but I can still advance my needle in there in a safe way in the midline, in a longitudinal view, where I can get my sample and then just get out and be done with it.
Yeah, no, that's brilliant. I should have said that. I usually try to measure and have an understanding. I'm going to say something that probably people are going to say is not true. I'm still not convinced that needle, specifically if you're doing a safety synthesis, is really going to puncture the lung and cause a pneumothorax. I think the majority of pneumothoraces, when you're draining a pleural effusion, occur because of too much negative pressure and quick re-expansion and damage to the pleura as the lung expands. That's my concern during the procedure where the pneumothorax is going to occur. Now, of course, if you jam the needle way in, you could probably make it happen. But if you go in nice and slow and steady, I think you're probably going to be pretty safe.
Interesting. Two questions come to mind, or two statements I want to make, is that please don't try that at home to try and prove Adam's point that you can't cause a pneumothorax with a needle. Yeah. I definitely
I see Randy's on. I'm sure he's going to do it now.
Oh, Randy's on?
Oh, yeah. I have no doubt he's going to jam a needle in just to prove me wrong.
Oh, I wouldn't do that. There you go, everyone. Randy has made an appearance tonight. He's on live. Okay, good. So we got that. So the first thing is obviously that. And the second point I want to talk about is re-expansion, pulmonary edema, how fast you should drain effusions, because to me, that is one of the biggest myths that I've ever been taught in medicine. So let me give you a scenario. Here's a scenario. You get called to a rapid response of a patient who recently left the ICU. They are clearly positive. They were volume up because they were resuscitated with crystalloids, as most patients are, and they were extubated. They went to the floor. Now you get called for a rapid response. They're short of breath. You do the ultrasound, gigantic pleural effusions, and that's likely the reason why this person is not ventilating well. And you know you have to drain this effusion. So I want to know, which effusion do you drain if it's bilateral? That's a gimme. That's your warm-up pitch. But the real question I want to know is, how fast do you drain, and do you worry about any complications if you drain too fast?
Okay. So, a lot there. First statement is, I do not think a subacute or chronic effusion causes hypoxemia. So I want to make that statement first. So the patient that has a big effusion from hepatic hydrothorax that is hypoxic, I don't necessarily believe that is what's causing the hypoxemia.
Well, let me just say, this is not a person this is a person who's third spaced from their resuscitation. This is not hepatic hydrothorax. Right. This is just a person who's simply volume up and was not diuresed post extubation. Right? They weren't de-resuscitated. So that's the patient I'm giving to. It might be the same answer.
I understand. I just took the opportunity to make that statement. So in this patient, for example, if you're trying to treat hypoxemia, I'm not necessarily sure drain it. Now, in a large acute effusion, which this one probably classifies for, probably can get hypoxic from it. But likely the hypoxemia is more likely driven from the pulmonary edema that's associated with the pleural effusion, right? So drainage of an effusion like this is going to improve diaphragmatic excursion, improve symptoms, definitely improve ventilation, variety of other aspects. So which one do I drain first? Usually the bigger one.
Sure.
I don't have a preference size. Do I believe in re-expansion pulmonary edema? I was anticipating you asking me that question, and my response to you is going to be, Dr. Malignant, have you ever seen a patient with re-expansion pulmonary edema? Because I believe in negative pressure pulmonary edema, right? I do not believe in re-expansion pulmonary edema from a large volume thoracentesis.
Absolutely. I completely agree with you. And this is something that I was taught in residency, and it wasn't until I think it was David Feller-Cotman from Hopkins who did probably the biggest look at that. And don't quote me exactly. We can put the links in the show notes. But what they looked at patients that they drained, all sizes of effusions, and they found that there was very low risk of re-expansion pulmonary edema. And even there was no rate of re-expansion that was too fast for people. The only predictors of people that would do badly are people that it wasn't coughing or it wasn't shortness of breath. It's actually people that had chest pain that was worrisome, and then people that had chronic pleural effusions that were drained too quickly. In other words, the hydrostatic forces have accommodated, and now you're opening up too fast. But to me, that was permission to drain people very quickly, because with the example that I gave you, I don't necessarily think you see hypoxemia, but what I do see, especially in older people, is that they have a loss of their tidal volume and their residual function.
100%.
So those people work very hard to breathe, and it's only until you take away that pleural effusion that you let them re-expand that they have better ventilation. So for those people, I personally just let it rip. I have not seen any re-expansion of pulmonary edema. I drain as quick as I can, because the point is they're in respiratory stress, and if I wait too long, then we're going to be putting a tube in that person.
Yep, I agree. I always find it ironic that I've been told to stop at 2 liters.
Yeah.
And 2 liters is the size of the bag that comes with the kit. I've always
2
found
liters?
that ironic. Yeah.
Oh, I was told 1 liter.
1.5.
Is what I was told.
Yeah, I've heard 1.5 too. Yeah.
It depends what institution and what equipment that you have. That's the limit.
I drain it all. Now doesn't mean sometimes you'll put the chest tube in, you'll start to drain, they'll become hypotensive or they start clutching and they get pain. Then I will clamp off, right?
Yes,
I'll clamp.
Right.
I'll let them settle down, then I'll open up and let it drain some more. It doesn't mean that I just willy-nilly drain everything and walk away.
Right. I mean, most people will get better once you get to like 400 or 500 cc's, but you try to get it all out. But yes, if they're actively having chest pain, it's time to clamp and stop. Also make sure that you didn't cause any other injuries. Maybe at that point you're going to, sometimes you're going to say, X-ray, I need you to come a little bit faster, even though it's always a stat X-ray. But come up and take a look. I want to make sure that everything's okay. But completely agree with you. Are there ever, since we're talking about re-expansion pulmonary edema, or I should say negative pressure pulmonary edema, when do you see those cases?
Yeah, so I think the one I see that comes to mind the most frequently is the patient in the OR or PACU who's intubated and waking up And as they're waking up, you don't quite get the tube out. They bite down, take a deep breath, and that crazy negative pressure causes pulmonary edema. That's
Yep.
the one that comes to my mind.
Absolutely. And the other that, maybe I'm speaking a little bit wearing my emergency medicine hat is the person who is overdosed on narcotics.
That was going to be my second. Yep.
And they slug in the Narcan. Even if the
Yep.
person's not hypoventilating, this I try not to talk about cases, but theoretically, this might have happened a few weeks ago where there was a patient who was breathing. They were somnolent, but they were maintaining their airway. They were breathing okay, and there was this motivation to completely reverse them because they were overdosed. And one of the complications that you can have, again, if you reverse them quickly, they're going to take a big intrathoracic breath, and they're going to translocate fluid, and that can actually lead to people being intubated. And I've seen that before. So we have to do no harm first, and just know that you should not give massive doses of Narcan unless the person is completely apneic and not ventilating at all.
Man, you're gonna hit on two of my pet peeves in one show: surgical chest tubes and Narcan drip. Oh, the Narcan drip gets me every time. I just don't
Narcan
get
drip.
it. I just don't get it.
Yeah, Narcan drips, not something I use often. I would say that only when you have someone who is like a pretty bad methadone overdose would be the only time.
Fair enough.
I'm learning a lot about you tonight. I know what to rile you up. It's not that hard.
Yeah. Yeah, I've seen some bad arrhythmias from Narcan too. I agree with you.
Yeah.
Definitely agree with you.
All right, let me just get to a question first. And by the way, like and subscribe if you're just joining us. We're talking about pleural effusions with Dr. Adam Green. Let's go to a question. Hang on. Oh, it's from Randy. Actually, it's a comment saying positive pressure, Lasix, and watch. How quickly, if you're going to see a person who has big pleural effusions, who's in respiratory distress, how quickly do you think that works, that Lasix? I mean, positive pressure makes sense, but how quickly do you think Lasix works for that particular person? You've seen a couple people who are in respiratory distress. What do you think?
Can I say it depends?
That's a medicine hedge.
Yeah, that's right. I don't have a set time. I think it always depends on a variety of factors.
You just literally said the thing I said not to say, but you just said it differently. Can I say it depends? No. Well, okay. So they look at a variety of people, and then it really depends on the thing. All right. So it just depends. I don't want to hold your feet to the fire.
Yeah, I think it depends on the degree of respiratory distress. Because I think what Randy is saying is, do you need to tap that effusion or not?
Mm-hmm.
And I think if they're coagulopathic, if there's reasons to maybe there's increased risk, I may hedge a little bit. But yeah, I think for the most part, if they're in acute, severe respiratory distress and there's a huge effusion, I'm pretty fearless and I'm happy to drain it.
Okay, great. I've heard something about tunneled catheters, although in all honesty, I've never seen one, just like I've never seen a 36 French percutaneous pigtail. What are these tunneled catheters?
Like you've never heard of Spira or a Pleurex? So
the Pleurex catheters. Okay,
yeah,
gotcha.
Same. That's what a tunnel. It's just a tunnel indwelling pigtail.
Okay,
chest tube.
perfect.
So,
sure.
Yep.
So for everyone at home, what are Pleurex catheters? Those that haven't heard or seen them.
Essentially, like a tunnel dialysis catheter, right? It enters the skin, travels through the soft tissue, and then goes into the pleural space to allow for routine drainage of recurrent reaccumulating pleural effusions.
Who would be people that have that?
So, I think there is truly one indication for it, and recently I will support a second indication. So the first indication, and most obvious, is malignant pleural effusion. So generally speaking, if you have a malignant pleural effusion, by definition, you're going to be stage 4, right? You're going to have less than 6 months, less than a year, depending on the diagnosis. Cancers I think of most frequently in those scenarios would be lung, renal cell, amongst others. And so you decide to put a Pleurex in. So who should get that Pleurex? So first off, you drain the effusion, and there is symptomatic relief. So that's important. A recurring pleural effusion, where each time you drain it, the patient feels no different, they don't get a Pleurex, right? So symptomatic relief, and it recumulates. Those are the two things. And then also, of course, they're malignant in end stage. So those would be the criteria needed to put in a Pleurex catheter. I'm fearful of them because they get infected. And you notice I didn't say that the lung re-expands. There are times where you drain these chronic effusions, they have a pneumothorax ex vaccio. That's okay as long as they get symptomatic relief, the effusion comes back, and it's a malignant pleural effusion. Those would be the people that qualify for an indwelling. The second group, which is a little more recent, like during my fellowship, we would never have done this on them. It's those with severe heart failure, recurrent heart failure effusions, who you have maxed out your diuretics, right? And they're getting renal insufficiency, or they can't tolerate more higher doses of diuretics, and they get symptomatic relief, and it recurs. Those are the patients that, and they're end stage. So we're talking about severe heart failure, less than 6 months, 12 months to live. Those are the ones that maybe I would think about putting an indwelling pleural catheter.
All right, well done, well done. Okay, couple final little questions here. What's the biggest effusion in CCs that you've ever drained?
Ooh. I'll go probably more than 2, less than 2.5. I don't think I broke 2.5 liters.
On one side?
On one side.
Jesus, that's a lot. All right. Pigtail catheters for pneumothoraxis, even though we're talking about pleural effusions. Yep. Anterior, side, back, what do you do?
Anterior. I mean,
right.
Sometimes you get that weird, like very loculated kind of, down in the gutter pneumothorax. All right, so maybe I'll go mid-axillary for that. But generally speaking, air rises, so I'm going to go up here. I go up here, and, I always remind every fellow or everyone putting it in, you want to go mid-clavicular, which is a lot more lateral than you think. It's very easy to go too medial, which is scary, especially if you're on the left side. So I go anterior always, second intercostal space.
And when you're doing that, do you do the whole thing with the bubble and the syringe trick?
So I don't know the bubble and the syringe trick, but
okay. So I'll tell you. Tell me what you do. So essentially, what you do is you put some. I mean, typically I'll use lidocaine because you're numbing up the periosteum as you're going down. But essentially, what you do is you leave some air in your syringe as you're aspirating down. So you have lidocaine, you have a little bit of air, and as you're pulling out, when you get into the pleural space, it'll start to bubble, and then you're in the pleural space.
Oh. Okay. Yeah, I mean, I guess I do that. I don't necessarily leave air. You should still see bubbles.
That's true. That's fair.
You should still see bubbles.
It shouldn't matter. Correct.
But I do what you said, which is, I think the tendency for the procedure is to use the little tiny lidocaine needle, and you give the lidocaine, and then you go and you say, "Oh, I'm in," and then you come out, and then you get the finder needle. I don't do that.
Yeah. I
use my finder needle from the beginning, and I'll tell you, I know I'm not supposed to use. You don't want to use cases, but I will remember a case where, and it illustrates a good point, I think, where I was a young attending. I'm still a young attending. When I was a very young attending, and there was a young lady, overdose, cardiac arrest, bunch of CPR, pneumothorax from the CPR, and we were there. We decided to put a chest tube in. We gave her lidocaine. We went there. We gave a bunch of lidocaine, and we decompressed the pneumothorax just with the needle. She's on positive pressure ventilation. I know it's going to come back. I try to get into the pleural space with my finder needle. That pleural space is gone, right? Because we've decompressed the pneumothorax. So then I guess I waited an hour, let it recur, and then went in and put the tube in. And so from then on, I just use my finder needle with the lidocaine, and that way it's one stick. I'm not sticking twice. Get the bubbles, put the wire in, dilate, move on.
Right. And alternatively, if you have somebody who's very aware and you want to not harpoon them with that big needle, you might do just the finder needle for subcutaneous lidocaine, then switch your needle over. And again, just depositing lidocaine as you're going down, hitting the periosteum, and then you leave a little bit so that, like you said, when you plunge out, you get some air and you actually know that you're in the space. But yeah, the same thing with vascular access. I was trained that first you go in with your finder needle, and then you get your blood, then you switch, you leave the needle in there, that little tiny 23 French, and go over it with the big needle, and then you walk away from your patient, and then you realize there's just so much blood everywhere. Now with ultrasound, obviously you don't even do that. But the less pokes you can make in a person, the better, and all around for the patient's comfort and for everything.
And remember, the two most painful parts is right at the skin and right at the pleura. That's where I put the majority of my lidocaine.
Yeah, exactly right. Well, I think I ran out of questions, Adam. I just want to as I'm kind of summarizing, let's turn it over to the audience. If anyone has any questions that they want to drop here, now is the time. This is audience participation time. Ask us your questions. I'll turn it over to Adam. And I essentially just want to go back and summarize everything. Pleural effusions, it's more about when we're deciding where to go, try to go for the back first versus the side. But ultimately, if you're going to use ultrasound, go for the biggest pocket, right?
Love it.
When you're looking at effusions, there are ways that we can quantify effusions, although for the most part, it's experience in Gestalt looking for larger effusions. And right?
Yep.
Good. We can look at effusions and get the quality of them to see if they're completely anechoic or black around, or if they're septations or things that are like funneling around the pleural space. And that can give us an idea as to whether or not the effusion that we're going to drain and send to the lab anyway is transudative or exudative. But it's never complete until you send it to the lab, right?
Yep.
And then when I like this, yup, yes, yep. No, yep. And then when you're looking at the fluid and sending it to the lab, when you're considering whether or not it's an empyema, looking at the shift of the cells, like neutrophils versus lymphocyte, will tell you whether or not you think it's bacterial or if it's something like a lymphoma or something else.
Perfect. Yeah, and I guess I didn't mention, one thing to mention is when you're deciding between that simple and complex paradigmatic, we talked about empyema, but the difference there, that's where pH and glucose really comes in. So a complex paradigmatic will have a pH less than 7.2. Glucose, well, you have to kind of consider what the serum glucose is, but usually less than 60. And in those patients, the LDH is usually sky high, like 2-3 times the upper limit of normal.
Very good. And when we're talking about pigtail versus thoracostomy, they're, in your opinion, really you should have percutaneous Seldinger techniques for all your chest tubes. You can always go bigger, but it's better for patients. It's less pain. In your opinion, there really shouldn't be anything that you shouldn't handle with a pigtail.
That's right.
Perfect. And then the last point is when you're talking about managing empyemas, older versus younger people probably should go to the OR. Younger people should go to the OR. Older people, we should trial them with percutaneous drainage to treat them conservatively. But the longer that you wait, the more likely that they're going to be going to in the OR for an open thoracotomy versus a VATS procedure.
Perfect. And I know we mentioned the lytic and what that means. Mistrial, MISS 1 and MISS 2, I think is what you need to refer to if you're looking for dosing and how we approach it and how we give it. That's the algorithm to use.
Perfect. And what was the last? Oh, and the last point is that re-expansion pulmonary edema, that is a myth. Negative pressure pulmonary edema is a thing, but not when it comes to draining pleural effusions. When you have to drain a pleural effusion, go big, unless the person is developing active chest pain, or if the effusion is chronic, in which case, either of those two cases, you might choose to go a little bit slower. Does that sum it up?
That sums it up.
All right, awesome. Well, let's see if we have, we got a question from Randy. Hang on, we got to do this the right way. Hang on. We got to let the people know. There we go. All right. Don't read that, but I'm going to read it.
He wants to change his question.
He wants to change. You can't change your question. All right, we'll change the question. We'll just hang on and banter for a little bit. If anyone has any questions, please drop in the comments. Go ahead, Dan.
I want to drop one more piece of knowledge. Oh, we have a question here. How to use TPA Dornase with surgical chest tubes? Same way. So generally speaking, the way we use it is the dose I've always grew up on was I think 5 milligrams of TPA and I think it's 2.5 of Dornase. And the way you do it is I used to first I would push. There's usually a side port, right, that allows you to instill, and I would instill 10 cc's of just normal saline, push that through, and what that does is it just makes sure that it's free flowing and going to the pleural space. Last thing I want to do is push TPA and have it just sit in the tube. That doesn't do any good, right? So I push it to make sure it's through. Then I push my lytics, and then I push another 10 cc's, 20 cc's of normal saline to really make sure it gets flushed in there. Then I clamp it. And if the patient's able to, we used to, I don't know if there's science here, but we used to do it. We'd make them lay on one side for 15 minutes, lay on their back for 15 minutes, lay on the other side for 15 minutes, and then lay on their belly for 15 minutes to really get that to slosh around and break up all the loculations. Then you open up the chest tube and you allow for drainage. And what I would tell you is that there is always output. So it doesn't mean that you necessarily broke up a loculation and you achieved what you wanted to achieve. It may have just meant that you put an angry med into a space and it made things angry and you get fluid as a result.
Fantastic. Great question, Farhan. Thank you very much. What other questions do you have? Were you going to say something before we asked that question?
Yeah. My fellows would laugh at me. One of my favorite things to do is talk about Pseudo-Exudates. Have you ever heard that term, or is that's a really dorky pulmonary term?
I would never insult you, but yeah, it sounds like a dorky pulmonary term.
So there's a group of effusions. I think this is just so cool. That's why I'm mentioning it. There's a group of effusions that by Light's criteria meet exudative criteria, but from a physiological standpoint, they are a transudative process. And so the classic example is a heart failure patient that's gotten a ton of diuretics, right? A ton of diuretics. And so you tap it, the effusion, and usually the protein is low, but the LDH meets criteria. And when a group of these effusions were looked at, all exudates and transudate, they found that 25% of the exudative effusions met that criteria, which just kind of blew my mind. And the reason I bring it up is because just because the Light's criteria says one thing doesn't mean you have to anchor on it.
Now I know what you pulmonologists talk about when you guys go out. That sounds really awesome. What other questions do we have? Randy says they're very expensive to put in on the floor. What is that? What do you think that is? That's very expensive to put on the floor.
I don't know.
Huh.
Maybe he's talking to his wife about a piece of china that his daughter is going to destroy.
Sounds like there's some inside joke going on, Randy.
No, there isn't. There isn't. I was literally just trying to come up with something. That's all I had.
Oh, I see. I see what you did there on the floor. Very good.
Yeah.
All right. Well, not a ton of questions. Maybe it's better that we wrap this up. And, of course, we'll take comments in the comment section for this video. But, Adam, it was really a privilege to have you on as a guest this week. It made my job easier, not having to coordinate who's going to ask which question. I just ask you a ton of questions, and you field them all. And well done, my friend.
Thank you. I hope it was informative. I enjoyed it. It's hard to sometimes sit and just listen to other people talk, and all you want to do is jump in there. So this was a nice opportunity.
No, it was fantastic. It was a great show. And again, this is one thing that people have trouble with. Pleural effusions, I think there's definitely some science there, but there's also some style points, and you nailed both. So I appreciate that. And Randy said it's TPA Dornace that's expensive to put in on the floor. All right, good to know. Maybe. So if you're in the black market and you want to sell TPA Dornace, just know it's you can make some bucks there. It's expensive to let drip out on the floor. All right, well, we're going to leave it at that. All right, and we're going to be back in 2 weeks. We're going to be back with a special show in 2 weeks. Adam, do you want to tell the people what we're doing, or should we leave it as a surprise?
Yeah, I want to. No, I think we should. I think I think that it's going to be really special. I hope people tune in for it. So we have our boss, Dr. Puri, and his father, who are going to come and talk about. You want to break it down?
I'm not good. Yeah. We are going to talk a little bit about the history of critical care. Something that I got to be honest with you, when you're just getting into critical care and you're doing all your rotations and you're learning the science, there's just so much that's thrown at you. But I don't think it was until I was a few years out as an attending that I started to have a deep appreciation for all the great historical context that is critical care medicine. Resuscitation, cardiac arrest, all the studies, all the crazy stories about people doing crazy experiments. Where do we come from with fluid boluses and just all the wacky stuff? And so we're going to be lucky enough to talk to somebody who's lived through it all and has known on a personal level many of the legends that you recognize when it comes to critical care. And so we're going to have him on in 2 weeks, and we're just going to ask him a ton of questions. He's going to tell us a lot of stories, and of course, we're taking questions from you, the audience. So I'm very, very excited to speak to the Puris. Dr. Puris?
Dr. Puris.
Dr. Puris. It's going to be a lot of fun. All right, my man. Well, thanks again for all your education. I truly appreciate it. It was good having you here, and we're going to see you next time.
Absolutely. Thanks for having me.
All right, folks. Thanks. And don't forget to like and subscribe to the channel. Again, we're over 10,000. Let's get to 20,000 by next episode. So thanks again for following. As always, leave your comments below, and we'll put references for this show in the show notes. Until we see you again, be happy and be healthy. Be safe out there. We'll talk to you soon.
Go Sixers.
Go Sixers.